pleasure to welcome Dr. Clara Chow, all the way from the University of Sydney, Department of Medicine. She's going to speak with us about very challenging emerging world of digital health. Is there realistic hope? Is it hype? Probably a bit of both, but I'll pass it over.
Thank you. Let's just start. Firstly, thank you very much for inviting me back. As with Kartik, it's now been nearly exactly 10 years since leaving a wonderful period of my life, I suppose, at PHRI. It's actually, Christmas 2009, which the time that I left. So, I mean, thank you again to Celine for being a most amazing mentor and continuing that job for the following 10 years. At any rate, I've been asked to speak about digital health, hype or hope. Hope or hype. I've chosen 5 use cases. There's so many things to talk about in digital health these days. So I've picked a few. So in continuing the story, in the first year I got back, I was applying for all these grants in Australia, trying to get something up, as you do when you get back to your country. And I threw one of them in called the TextMe study. And this was the first grant I got back when I got home. TextMe stands for Tobacco, Exercise and Diet Messages, and it was a little bit of a left field thing, and I had never really forayed into digital health. At that time, not many people had. This was a very simple, single-blind, randomized clinical trial where we took 710 patients with coronary disease and randomized them to interventional control. We wanted to look at objective measures of risk factors, and so we looked at LDL, cholesterol, blood pressure, smoking cessation, exercise and diet. And yes, that's a picture of my phone at the time and some of the messages, and you may or may not be able to see them, but they had your name in it. So the first one says, Clara Exercise is good for your physical and mental health and your quality of life, from Westmead Hospital, text me. We actually spent a reasonable time developing this program. We started with clinicians, public health experts, psychologists, allied health, and we brought together our bank of messages. We only had about 110 messages, so we had to be fairly careful with how we selected them. We wanted them to be advice, motivational, supportive, and provide information, and we focused on lifestyle. 4 main areas, and that was general heart health, nutrition, physical activity, and smoking cessation. At the same time, one of the guys in our sort of actually EP lab that made EP catheters was doing some programming on the side. So actually we then programmed the software to manage the text messages and customize them. So, whether people were a smoker or non-smoker, vegetarian or not vegetarian, we followed an algorithm to, I suppose, deliver the text messages to those individuals. There were about 4 messages per week, and each one was delivered at a random time slot during that week, but within reasonable sort of hours. So our main results table, and I have to say we were incredibly excited that it got accepted into JAMA at that time. We got a lower LDL cholesterol, a lower blood pressure, a lower BMI, and really all the risk factors went in the right direction. I suppose the excitement here was really a relatively light or small or low cost intervention was able to change risk factors. And I suppose the other sort of thing that we were excited about, and I think others were excited about, is that we were able to target multiple risk factors simultaneously, which is what you want to do for cardiovascular disease secondary prevention. So if I just ask you to look at the second bottom line there, achieving greater or 4 out of those 5 key risk factors was 28.9% in the intervention versus 10.3% in the control. So interestingly enough, that program of work has really expanded, and now we've run or are running multiple texting trials here in medical adherence, in diabetes, in COPD, in gestational diabetes, in kidney disease, in musculoskeletal back pain, in mental health, in breast cancer, in adolescent obesity, and final one in perioperative smoking cessation. And all of these have arisen from collaborations, are led by different groups, and we assist them. And I suppose some of our challenges are how to integrate these programs so we can deliver, I suppose, an overall customized program for people with multiple morbidities. So I suppose the question of whether this is hope or hype would be, I would say that it's hopeful. I mean, text message-based interventions have now been delivered as part of public health campaigns in a number of countries. So for example, this is a smoke-free text messaging program in the US, and they're in the UK and New Zealand and Australia and in a number of places. And perhaps this shows potential for us to be able to deliver customized and targeted health promotions interventions at a relatively low cost, which sort of fits with the health promotion paradigm. And actually not yet in the public space, we're about to roll out Text Care in Australia in a partnership with the Heart Foundation to deliver the Text Me program to people in Australia. And as a number of people here supported, this was due to funding that we received from the Google Impact Challenge. All right, so to another case or example. This is about Care Here. Now this is a very well-developed app which was integrated with electronic health record. It provided individual care plans, additional information, a social network, personalised targets, and SMS or email reminders. So some of the key things about success in apps are that they're integrated with existing health systems and they do address multiple things. So Care Here was evaluated in the US. This is 2011 to 2014. It was an incentive plan for employees to improve health. 81 employers were involved in 42 states and 30,974 employees were involved. The majority were white and in government jobs. The employees were offered the opportunity to participate. They had to complete biometrics at baseline and they could opt out of the digital health program, but they all had to download the app. Now, the participation was classified into use. So actually, in terms of not logging in again, 14,173 did not log in again. Very low users, that's less than 12 per year, that was 12,260. So that covers the majority of the people that got the app in the first place. Then 3,360 were using it monthly, weekly 651, and semi-weekly 265. The program users were likely to be older, female, more obese, and with higher glucose and lipids. And they reported weight change as per usage. So if you didn't use the app, you put on weight. And if you used it bi-weekly, you lost 5.2 pounds. They reported that there was significant weight loss with high DHI usage. But obviously the key issue here is that there was not high DHI usage. I mean, people did not use this digital health intervention. And this has been a problem in the app story. I mean, apps enable us to do, you know, a lot of nice potential programming, integration, a lot of gamification, a number of incentives, a number of things within apps, but they still are a pull technology. You have to pull them down, you have to upgrade them and, you know, sync them and things. And it's an interesting issue that even though they may work, the question is, can they be implemented at large scale? So I'd say that this might be, you know, a potential example of hype, or maybe not yet success in working out how to make a successful app. All right, just so another case here. This is SMS Lifesavers to explain people with an out-of-hospital cardiac arrest. The dispatcher would identify the location of that out-of-hospital cardiac arrest by the GPS location of that person's phone. They would then match it to the nearest SMS Lifesaver, which would have a phone with a GPS location system and be a volunteer that would give CPR. They would match the two and call the SMS Lifesaver into that out-of-hospital cardiac arrest. This was evaluated in a randomized clinical trial in Stockholm. It was a blinded trial, no consent, quite forward thinking really. Patients with suspected out-of-hospital cardiac arrest was the sort of main patient population. Volunteers were trained in CPR, and by the end of the study, about 10,000 volunteers were trained in Stockholm. The intervention group, the mobile phone positioning system, would call that volunteer in, and in the control, they would not receive a text message to be called in. The proportion receiving bystander CPR was the primary outcome, and there were 1,808 suspected cardiac arrests, of which 667 were actual cardiac arrests. Now, bystander CPR was initiated in 62% of the intervention group compared to 48% of the control group. And I'm sure Dr. Yusuf would say they should have done a larger trial, because maybe they could have got an outcome difference in mortality there. Looks nice, but it's not significant, 11.2% versus 8.6%. But really quite an exciting use of digital health, global positioning and text messaging. So Good Sam is a very similar style app, and this app has actually, does basically the same things. There's a number of apps on the market that do this, but the key thing here is integration with paramedics or ambulance services. And this has actually just been rolled out in Victoria, one of the states in Australia, and we're looking to roll this out in New South Wales as well. But, I'd say that this is an example of hope and potentially success of this awful public health problem that is out-of-hospital cardiac arrest, and really the importance of first response. All right, so touching on another one. So I thought I had to do this, and this was the large-scale assessment of a smartwatch to identify AF, which I think a number of you might have seen in the New England Journal just recently. So this is effectively a monitoring study. US adults greater than 22 with no previous AF, English speaking, 419,000 from 50 US states, 42% female, average age 41, 5.9% only were 65 years and over, and 52% were between the ages of 22 and 29. You can see some of their risk factors there. So the Apple Heart Watch used here use irregular pulse notification. Now, you know that there's other means of doing this, but anyway, irregular pulse notification algorithm, which was triggered by the photoplethysmography, which is on the back of your Apple Watch sensor. And the participant was notified through their app if it was irregular and told to seek a telemedicine visit. Now, I've tried to put this together in a bit of a picture to try to explain what I think are the findings of this result. So as I said, 419,000 included. The median follow-up, as in the median times they were monitored, was 117 days. Now, 2,161 or 0.5% got a regular pulse notification. 50% notification was by day 38. And then they got sent a patch. So the Zeo patch was used as their validation. A Zeo patch can get continuous AF monitoring for about 2 weeks. It was worn on average in this study for 6.3 days. 64% returned a survey when they got a notification, indicating that about 57% of those, so about half of that, actually went and saw a doctor after they got a notification, which I think is an important thing to know as well. Now, 945 only were included because that's the number of people that, initiated the visit, even though there was 2,161 that actually got a notification. And 291 were excluded because of prior AF and a number of other things. So 945 were left. So of that, 658 had the patches, but 208 were then excluded because either their patch didn't work or it was unreadable or they didn't return it. So in the end, you get 153 out of 450 or 34% with AF. And continuous AF was about 1 in 5 of those, and the rest were paroxysmal AF. Now, in terms of the sort of result reported in the abstract, and that was the positive predictive value of 0.71, that was actually derived off the tachogram result. So amongst all those people, they got 2,089 tachograms, and 1,489 of them showed AF, and that's how they've calculated the positive predictive value. So at the end of the survey, at the end of the study, they sent a survey to everybody. Now, only 43% of the notified group responded, and 44% of them, or 404, reported they had AF. Among the 417,000 that were not notified, 70% response. 3,070 actually said that they had developed new AF. Okay, I know I ran through that quickly, but in summary, I mean, the watch identified 153 people with AF in this study of about 500,000 people, but they missed at least 3,070 from that survey result, and that's only from survey self-reported people, and not even a complete response rate. The 0.5% notification rate was at 100 days, but what if that was cumulative? What if that was actually different people? So that might mean that 6% might have some notification of which a large percentage of them seem inaccurate. 66% of the notifications were not AF. Among those that got a notification, 57% followed up with the doctor. So if Apple can detect rapid AF, and other things they detected were pauses and non-sustained VT, who is responsible for these findings? So one thing, you know, I mean, that was commented on is that the wrong people got the Apple Heart Watch. I mean, you know, Apple, well, very simple back of the envelope calculations, made $21 million from all of these Apple Watches. And 130, you know, if I say they're about $500, that's 137K per detection of AF, which may have been, you know, only 5% of the AF cases in that whole entire population. So some studies answer questions and some studies raise more questions. So I'll leave you with that. I'm uncertain whether that's hype or hope, but at the moment, I don't know that I can clearly say it's hope. All right, look, I'm going to rush through one last example. Now, everybody knows that AI is increasingly being talked about in healthcare, and really the rise of AI in health and medical research has been exponential. Just one reflection here from a consumer point of view. So what is this? This is patients' views of wearable devices and AI in healthcare. So the red bars at the top of this are people that are completely against the use of AI in healthcare. You can see that's a consistent, probably 20% across all of those use cases. The blue is the ones that are ready for use, and you can see it's increasing across the bottom here. And so what are these? These are skin photographs to screen for cancer. They're very unhappy about using AI, or not really prepared for it in that case. The next one is monitoring, real-time monitoring of predictive flares. The next one is smart shirts to guide physical therapy. And the final one, where people seem to be more prepared and willing to accept AI, are AI chatbots to help patients determine how urgent their problems are versus calling the emergency department. So actually, a couple of months ago, we just won the Google AI Challenge, which was the inaugural competition in Australia. So admittedly, so the idea here was to start utilising data from wearable devices as well as other information to start prompting or triggering the text messages. You know, so if you arrived in front of McDonald's, perhaps you would get a text message to remind you shouldn't be there. But at any rate, it was that type of triggering, utilising information both off their GPS and other information. Now, I'm not sure if we're going to kick this off, because at the moment the University of Sydney and Google are having quite a conversation, because the contracts are clearly in favour of Google at the moment, but we'll see. All right, so this last slide, I think, is an example of where AI is already being used in healthcare. Now, this is ELISA, activating individuals through personalised conversations, a very large company, HMS, in the US. And what they do is that they take data, they're a data storehouse, they take data, they use predictive modelings, they use engagement designs to have personalised conversations with individuals to try to get them to their healthcare providers or get them to you know, health services. And they use IVR, they use information about their voice to change the conversation. And they then feed that back as data in, and the circuit goes around to create more personalised and customised conversations with patients. Now, this company is massive, and you know, it is solely at the moment operating in the US. I know about it because they want to start their work in Australia and have asked us to be their initial site. But you know, this is perhaps an area where, you know, there is success in utilisation of AI digital health interventions already. All right, so thank you. I'd like to finish by saying I think digital health is here to stay. I think there is a lot of hype, but I still think there is a lot of hope. Of course, the challenge is sorting out the two and probably not getting distracted by all the fancy new technology, which I constantly get distracted by. Well, the future may be integration, and certainly that's what a lot of us has been talking about, integration with existing health systems. But perhaps the future may be in complete disintegration, complete disruption. And you can ask me about that maybe later. Thank you.